Respiratory Part 2. Here's your objectives. Ava changes breath sounds. So you got your bronchi, you got your wheezing, you got your notable no breath sounds, which means a pneumothorax. So acute respiratory failure. Acute respiratory failure. There's two main classifications of this. The first one is a ventilator failure, which means there's a physical problem with the lung or the chest wall. There could be a defect in the respiratory control center talking to the brain, and you could have poor function of the respiratory muscles. A lot of the times this happens from a trauma, a pneumothorax, and then you can have oxygenation failure, which there's an insufficient amount of oxygen in the pulmonary blood at the alveoli level. The ventilation is normal, but the lung perfusion is decreased. The best example of this would be a pulmonary embolism, a PE. Acute respiratory distress syndrome. A lot of times this is related from a transfusion, a related lung injury. We call it TRALI, T-R-A-L-I, transfusion-related lung injury. So that can happen from infusions, so like blood transfusions. Okay. This patient is going to be restless, unable to follow commands, very agitated, very confused. When you're going to check an ABG, they're going to be incredibly hypoxic. And when a chest x-ray is done, this is when you have a whiteout chest x-ray. This could be from, like I said, the transfusion. It also can happen from near drownings. A lot of times this patient can come unresponsive. And when they become unresponsive, you need to call the doc, especially if their oxygen level is going down, because this patient is going to have to be ventilated. We're going to have to put a ET tube down, or this patient is not going to make it. We also see this patient occasionally with very severe asthma. And a lot of times they're in the ICU for treatment. And if you didn't know, the most common treatment for asthma-induced ARDS is magnesium. And magnesium IV is used as a bronchodilator. So non-invasive positive pressure ventilation. This is a BiPAP or a CPAP. It's used to push positive pressure to keep the villi in the lungs open and improved gas exchange without ET intubation. This is what an ET tube looks like, though you probably know that by now. Most of the time, a respiratory therapist or an MD, a mid-level, will place an ET tube in. Intubation itself. If your patient has a low respiration rate, their pulse ox is dropping, and they are unconscious, that is the time for the nurse to start preparing for a ET tube placement, an ET placement. We are going to be ventilating this patient. Once the tube is placed and the chest x-ray is completed, you're going to want a chest x-ray for verification. And we do keep their head of the bed up 30 degrees to 45 degrees just to keep pneumonia at bay. The actual steps of intubation, the first one is the patient is going to have to be sedated. So the first thing we're going to do is sedate the patient. This is done most of the time with propofol. Second thing, oxygen level at 100%. We're going to hyperventilate the patient. Once the ET tube is down, the cuff needs to be inflated. So at the tip of the ET tube, there's a small cuff, just like a Foley catheter. And then we push air into it to inflate the cuff. The fourth thing is we want to put on the CO2 detector if there is not one already attached. Nowadays, they tend to come attached. And the fifth thing, is a chest x-ray for verification. So those are the 5 steps. Let me go through them again just to make sure you got them. Sedate the patient, 100% O2, inflate the cuff after the ET tube has been in place, attach the CO2 detector to make sure we're getting CO2 back, and a chest x-ray for final confirm. So barriers to care, mobility. It's going to be hard to get the patient up and moving, though I have gotten a patient up and moving while they are still ventilated. You can do it. It's easier if they're in a BiPAP or CPAP, but all the machines do have to come with, obviously. And communication is a barrier. If they are on mild sedation and they can communicate using a whiteboard or the pictures or an alphabet, that's what we'll do. A lot of these patients are too sedated at first to be able to do any of that. We do have to keep them moving, even if it's just repositioning back and forth to prevent any type of bed sores, pneumonia. Like I said, we keep their head of the bed up at 30 to 45 degrees to keep pneumonia from setting in. Mechanical ventilation, okay? So some aspects with mechanical vent. Let's talk about the alarms. Low pressure alarm. So all the alarms on the little monitor that will come up. One of them is called low pressure alarm. Low pressure alarm means the patient is not getting enough O2. So a couple reasons this could happen. The patient could be biting on the tube, which is a normal response. So we do have to look at the tube, possibly increase the propofol, sedate them a little bit more, and sometimes we have to manually bag the patient for a little bit just to make sure. But that's one of the most common ones that you're going to see. If the patient is breathing too fast, we could see this for a couple different issues, but if the patient's breathing too fast, whether the machine is set for a higher respiration rate or the patient's breathing over the machine, you're probably going to see respiratory alkalosis. And then the respiratory therapist needs to come and change the settings a little bit, and the patient probably needs to go up on the sedation. Like we talked about previously, if the respiration count is too high, the patient's probably going to be in respiratory alkalosis, and the vent settings need to be changed, and the manual respiration rate does need to come down. different sedation agents, okay? A lot of times, along with the propofol, which is the sedation, they are also put on neural blockers. If the patient's going to be on a neural blocker, they absolutely need to be on propofol. Propofol is real nice to use because it has a very short half-life. So if you turn it up, within a minute or two, you're going to see the effects. If you turn it down within a minute or two, you're going to see the effects. Very common neural blocker you're going to see is casrocrium. I always say that wrong. I'm going to spell it for you. CISATRACURIUM. If the patient's on neural blocker, they absolutely need to be on sedation. All right, some nursing care. If for whatever reason the ET tube moves, first thing we do is check lung sounds. That's the first thing we do. Okay, even if you think the ET tube has been moved, check the lung sounds. If you're doing any type of suctioning and the heart rate and the oxygen rate, or oxygen level, sorry, drops, you need to stop suctioning. Let's go through the steps of suctioning via ET tube, okay? First thing we're going to do, there are 6 steps, okay? First thing we're going to do is assess all vital signs, right? Just have your baseline done. Second thing we do is we're going to hyperoxygenate the patient. And do yourself a favor, turn off all the alarms because they're all going to go off on you. Third thing is you slide the catheter through the ET tube down to the lungs. You only suction as you're removing the catheter. Repeat if needed, and then document. So let me go through those one more time. Number 1, you assess all vital signs. Get a baseline. Number 2, you hyperoxygenate the patient and silence all the alarms because the alarms are going to go off on you. 3, slide the catheter through the ET tube down. 4, suction only as you're removing the catheter. Never suction when you put the catheter down. You only suction as you remove the catheter out. 5, repeat if needed. And then 6, document what you did. Like we talked about earlier, if the patient pulls out the ET tube and they are not breathing well, you will have to manually ventilate until help arrives. That's why everybody that has an ET tube or is on a vent should have an ambu bag next to them. Some of the complications we can see, especially for people on long-term ventilation, the biggest thing you're going to see is GI issues. They can aspirate really easily. They tend to go on feeding tubes, so you have to make sure that the bed is up. Bed sores, just normal skin breakdown. And then they can have muscle deconditioning, so everything just kind of starts to go limp on them, okay? If they're not using the muscle tone, you're going to lose your muscle tone. So it is very important to try to get them off the vent as soon as possible, safely, but as soon as possible. Weaning the patient, always the goal. As soon as we get them on the vent, we want to have a plan to get them off the vent. So sometimes we do something called a sedation vacation to kind of see how the patient's going to react without any sedation on board, and it can be as short as 5 minutes with the nurse in the room. During a sedation vacation, or we're actively weaning, we're going to start dropping that propofol down. So we're going to decrease it little by little. We're going to stop that if all of a sudden the heart rate, the respiration rate, and the blood pressure shoot up. Okay. So if we're dropping the propofol little bit by little bit, and all of a sudden the vital signs all go up, stop weaning, go and then set the propofol back to where it was where the patient was still comfortable, okay? This is normal. Doesn't mean anybody did anything wrong. We're just testing out how the patient's fight response is. It's completely normal, okay? And then extubation. All right, so patient's doing pretty good. It's time to take that ET tube out, okay? So 5 things we want to teach the patient after an ET tube has been DC'd, because we don't want to put it back down. First thing is coughing and deep breathing. So that big, nice diaphragmatic coughing and deep breathing. Incentive spirometer, that little device we give people. Incentive spirometer. We're still going to keep that head of the bed up about 40, 45 degrees. Suction the mouth as needed. Get that saliva, that excess saliva out of there as needed. And then make sure we're resting the patient between activities, okay? There's a lot of thought process between the activities. This patient's probably going to have physical therapy, speech therapy, occupational therapy. I would span them out, schedule them with your auxiliary staff, that not all 3 services are coming at the same time. That can be immensely overwhelming for a patient, so it'd be something we want to span out. Even you could argue activity is eating. Even if they're on a clear liquid diet, give them a lot of time, help them. They're going to be wiped out. So we don't want to push too hard, and we want to make sure they're resting so their body can recover from every activity, and that's how they're going to get stronger. All right, I'll let you guys read through the questions on your own, and I will see you in class.